Hey, this is Neil Dasgupta. In this talk, we're going to review some ventilator management, specifically some strategies we can use to help patients who are suffering from respiratory failure because of COVID-19 and resulting ARDS. Our objectives. So we're going to go over some guidelines for safe intubation of COVID-19 patients. We're going to talk about specifically the volume AC ventilation mode. I really believe if you're going to learn one mode and learn it really well, that's the one that you can accomplish the most with in the shortest period of time. And we're going to go over how to employ a lung protective strategy to manage ventilated ARDS patients and COVID-19 patients in respiratory failure. So let's start with guidelines for safe intubation of these patients. The SARS-CoV-2 virus is highly infective and easily transmitted. The primary method of transmission is droplets, respiratory droplets, but contact isolation precautions are also necessary since the virus lives for an extended period of time on surfaces, and there is some indication that the fecal-oral route is also possible. While the virus itself is likely not airborne, those respiratory droplets do aerosolize, especially during respiratory procedures, necessitating airborne precautions as well. This is a list of procedures that may generate aerosols. Some of these are very common in our respiratory management, and so they should be used with caution. Any nasal cannula flow above 6 liters per minute, nebulizers including albuterol and Atrovent, awake fiber optic intubation, especially because of the coughing that would cause respiratory droplets to aerosolize. Any non-invasive ventilation, including BiPAP or CPAP. Bag mask ventilation. Some of that can be mitigated with a PEEP valve and using a tight mask seal. Using a T-piece when on the ventilator and open suction systems. As a result of this, we may need to change how we approach intubation in these patients. The decision to intubate should be made earlier, both because the patients can decompensate quickly, as well as the amount of time required to don the appropriate PPE and prepare to get in the room. We need to minimize personnel involved in the procedure. It should be performed in a negative pressure room. The patient can be pre-oxygenated with a non-rebreather and a surgical mask, either over or, in my opinion, it's preferable to put under the non-rebreather mask directly on the patient. We should eliminate as much positive pressure ventilation as we can, including BVM breaths. An airway checklist should be performed before entering the room to ensure that you have all of the materials and medications that you need to effectively and efficiently intubate. Ideally, a PAPR should be used, but otherwise, full protection, including an N95 mask, eye protection, face shield, isolation gown should be used. Video laryngoscopy is ideal to create some distance between the intubator and the patient. It should be performed by the most experienced person, and RSI should be used with no BVM breaths given from administration of paralytic to intubation, allowing the pre-oxygenation to carry you through the apneic period. The patient should be placed directly on the ventilator after intubation. So, now that we've got the tube in, let's talk about how to set up the vent itself. Volume AC, or CMV, continuous mandatory ventilation, is likely the mode that we're all most familiar with. This is a schematic of a ventilator and the variables that you can manipulate when using the volume AC mode. So you have the tidal volume, the fraction of inspired O2, the FiO2, the PEEP, the positive end expiratory pressure. I have them on the same dial, the FiO2 and the PEEP, and we'll talk about why in terms of the ventilation strategies. You can set the respiratory rate, and grayed out here is the inspiratory flow rate. If you're going to ignore one of the dials that are available to you, then this is the one to ignore on this vent mode. So what exactly is going on with volume AC? So you can set the respiratory rate, and mandatory breaths will be given at that rate. The patient can trigger breaths in between those mandatory breaths by supplying even just a little bit of negative pressure. Take a little bit of an inspiratory effort, and it'll trigger a breath. Every breath delivered is going to get the full set tidal volume. So if you set the tidal volume to 500 milliliters, regardless of whether it's a mandatory breath or a patient-triggered breath or how hard the patient tries to breathe in, they will get the full 500 milliliters with every breath. The ventilator is calculating how much pressure to apply to deliver that set tidal volume. It's going to take your inspiratory flow rate into account, but it will decide on the pressures. That's not something that you have to determine. So now let's employ a lung protective strategy to manage these patients on the ventilator. While not every COVID-19 respiratory failure patient that requires intubation will be in ARDS, or acute respiratory distress syndrome, it's worthwhile using a ventilation strategy targeted towards ARDS because of the clinical similarities and the overlap between those two entities. It's an acute onset with bilateral opacities. There's non-cardiogenic pulmonary edema, and there are variable amounts of PaO2 to FiO2 ratio, mild, moderate, and severe, which corresponds to the level of lung injury involved. What we want to do here is follow a strategy with low tidal volumes to effectively ventilate and oxygenate while preventing barotrauma and protecting the lung that's already been acutely injured. So here is the strategy that allows us to use each of the variables that are available to us to ideally target our patient. So we start with tidal volume. We set the tidal volume for lung protection. So our target tidal volume is between 4 and 6 milliliters per kilogram of ideal body weight. Now you can start at 8 milliliters per kilogram and see how you go, but you will likely have to come down in a true ARDS picture. The way you titrate is that you target a plateau pressure of less than 30. So immediately after intubation and then every 30 minutes or so, you're checking a plateau pressure, and if you're above 30 or getting close to 30, you're going to want to drop that tidal volume to protect the lungs. The combination of FiO2 and PEEP are for oxygenation. We're going to talk about how to use a PEEP scale to make sure you're oxygenating and keeping all your alveoli recruited and engaged. The respiratory rate is what controls your ventilation, your CO2 clearance. So you use the rate to target your PCO2 goals. If you check a gas and your PCO2 is too high, you want to increase the rate, and vice versa. You can start at 16 breaths per minute, check a gas in 30 minutes, and see how you want to go. Like I said before, the inspiratory flow rate is the setting that you can probably ignore without serious consequences. You can start at around 60 liters per minute, but if the patient exhibits any signs of air hunger, they look very uncomfortable on the vent, they're kind of gasping, you can titrate that up. You can raise that inspiratory flow rate to up to 120 liters per minute. Patients like to get most of their breath up front. It's how we breathe naturally. So sometimes increasing that flow can make the vent a lot more comfortable. This is just the picture I think of to remind myself to use height instead of actual body weight to calculate the targeted tidal volumes. As you can see, after we get to adulthood, the lungs don't really grow as the rest of us grow. And so you still have your normal sized lungs despite how much excess tissue you've packed around it. So please use a calculator, use height to calculate what kind of tidal volumes you want to give to patients. These are two examples of PEEP scales from the ARDS trial. I strongly recommend using a PEEP scale to decide on your FiO2 and PEEP. These two dials should be used in conjunction with each other to maximally deliver oxygenation. The way we use these is you decide on a FiO2 and PEEP as a starting point. For example, let's try on the lower PEEP scale, start at 0.5 or 50% FiO2 with a PEEP of 10. And if you are not getting acceptable O2 saturations at that level, then you go up on the scale, so up to 60% with a PEEP of 10, then up to 70% with a PEEP of 10, and once you're still not oxygenating at that point, you go to 70% with a PEEP of 12. Likewise, if you're at 50% PEEP of 10 and you're oxygenating fine, you're targeting between 92 and 96%, and let's say you're actually satting 100, you can come down on the scale. So you can come down on the PEEP to 50% PEEP of 8, and then down to 40% PEEP of 8. You can move up and down on these scales like that so that you're preventing barotrauma, you're preventing excess oxygen delivery, and optimizing what the alveoli are seeing. The most important element of a lung protective strategy is to prevent barotrauma, to prevent the combination of tidal volume and PEEP to injure an already injured lung. The way we monitor that is the plateau pressure. So this is the pressure that exists in the airways at the end of inspiration. So the peak pressures are not very helpful because biting on the tube or parts of the circuit can really change the peak pressure without actually giving us an idea of what the alveoli see. So the plateau pressure is the measure we go for. You have to learn how to perform an inspiratory hold maneuver on the vent. And the plateau pressure should be measured immediately after intubation and then every 30 to 60 minutes to make sure that your strategy is protecting the lungs and doing all the things that you want to do. We want that plateau pressure less than 30 to prevent the kind of damage that we're concerned about. You may have heard of the concept of recruitment maneuvers, or doing 30 for 30 or 40 for 40. The idea of these is in persistently hypoxic patients, you can use briefly sustained PEEP to open up collapsed alveoli and stent open airways to get gas exchange. Think of it as popping open the airways to then use less PEEP to still be able to oxygenate. So traditional recruitment maneuvers, you talk about going to a PEEP of 30 for 30 seconds or a PEEP of 40 for 40 seconds. There are also what's known as stepwise or staircase recruitment maneuvers, where you incrementally raise PEEP in increments of 2 to 5 every 3 to 5 minutes until you get to one of those high PEEP situations, and then drop it back down once you've recruited. Despite anecdotal evidence from those of us that do this that it's effective, there's no great literature and no definitive studies that have shown that these recruitment measures are actually effective at improving oxygenation. This infographic is from the Society of Critical Care Medicine, and it lays out a really nice stepwise approach to COVID-19 patients with acute respiratory failure. So on the left-hand side, the green part of the screen, you see the mild ARDS case. They're advocating for all the things that we talked about today. Low tidal volume ventilation, plateau pressures of less than 30 centimeters of water, investigate for bacterial infections, shoot for an oxygen saturation between 92 and 96%. You really want to go with a conservative fluid strategy here. More and more we're seeing that ARDS is an iatrogenic disease, probably born of imprudent fluid administration. So you want to have good endpoints of resuscitation, use ultrasound to guide your resus, and do frequent volume assessments to make sure you're not overloading these patients with fluid. You want to consider early empiric antibiotics, but the systemic corticosteroids, the place for them may not be in this patient. As we get into the sicker patient, the orange part of the screen in the middle, moderate to severe ARDS, this is when we're really looking at higher PEEPs, moving up on that PEEP scale, using neuromuscular blocking agents. So paralyzing these patients, either with bolus doses of medications like cisatracuronium, rocuronium, vecuronium, whatever your unit is using or what you have on hand, boluses or even infusions to take away the asynchrony between the patient and the vent and to help you reach your ventilation so the patient's not struggling against your ventilator. Obviously, that requires very deep sedation as well. You can consider traditional recruitment maneuvers like we talked about, but it looks like SCCM is categorically saying no to staircase or stepwise recruitment maneuvers. You can consider a short course of steroids here, but the role for other medications like antivirals, chloroquine, the other biologics is really unclear, and we're not sure where they're going to come into play. As we get into more of a rescue or adjunctive therapy situation in the gray box, this is when you're throwing everything at the problem. So medications that you have on hand, paralysis, prone ventilation, nitric oxide, and even VV ECMO for the really persistently hypoxic patients that's becoming impossible to ventilate. So thank you for listening. I hope some of that was useful as you continue to wage this war that's starting to overrun New York. Please protect yourself, get the resources that you need, reach out for the emotional support you need, because this is a brutal time for all of us. Thank you for keeping our patients safe, and thank you for all of your hard work, and I'll see you out there.